The first question is that it is associated commonly with which neoplasm, and the second question is which is the recommended initial treatment. Moving on to next question. A 6-year-old child presents with subacute onset of multifocal neurological deficits, including acute hemiparesis, blurred vision, and difficulty with balance, approximately 2 weeks after recovering from a common viral upper respiratory tract infection. On examination, the child is lethargic and disoriented, demonstrating encephalopathy unexplained by fever or postictal state. The image shown is the brain MRI done of the patient. Questions are: what is the most likely diagnosis and most commonly detected antibody in this age group for this presentation? We'll be moving on to the next question. A 15 months girl child came with history of full-term normal vaginal delivery, normal growth and development till 6 months of age. Later, she noticed to have slowing of growth of the head. The mother complained that the child one day woke up and was no longer speaking around a month ago. On examination, the patient had microcephaly and poor eye contact. She had been diagnosed as to have Rett syndrome on evaluation. The questions for this clinical STEM are: what are the most common gene defect in this condition, and what is the recommended specific treatment for this condition? Going on to the next question. A 5-year-old child from Assam presents with high-grade fever with chills and rigors for 2 weeks duration, followed by altered mental status. The examination also revealed a hepatosplenomegaly. Given at the peripheral smear slides of the child, the questions are: what is the causative organism for this infective condition and how will you treat it? We'll be going on to the next question. A 1-year-old boy with preterm delivery presented with global developmental delay, congenital cataracts, and spastic contractures of all limbs. Mother had a bad obstetric history and a history of febrile illness with rashes in her first trimester. The likely diagnosis and the classic triad of this condition. Image of the eyes has been shown. We'll be moving on to the next question. A 2-year-old child was evaluated for cognitive regression and on examination had oculomotor apraxia along with hepatosplenomegaly. Further testing had shown a reduced glucocerebrosidase activity in the peripheral leukocytes. The evaluation of bone marrow showed the following picture. The questions are: the presentation along with this histopathological finding is typical of which disease? And which phenotype of this particular disease has bony abnormalities in higher frequency? We'll be moving on to the next question. A 7-year-old child with acute onset fever and sore throat was managed by a pediatrician with oral antibiotics. After 3 weeks later, she had a sudden onset involuntary movements of shoulder shrugging, then was evaluated to have significantly elevated anti-streptolysin O titers. The questions are: what is the likely diagnosis in this patient and the agent of choice for treatment in this patient? We'll be going to the next question. A 5-year-old girl is seen in a neurology OPD. She was recently detected to have a left optic pathway glioma that is being monitored by her pediatrician and being managed as a case of neurofibromatosis 1. She is doing well in her education and her physical examination findings are significant only for multiple cafe outlet macules, which are at least 6 in number and greater than 5 millimeter. The questions are: the highest risk of development of optic nerve glioma in this condition is seen in the age range of. And the second question is to name any one approved treatment option for an inoperable neurofibromatosis 1 related plexiform neurofibromas. We shall be moving to the next question. A 5-year-old girl with history of vesicular rash with dew drop on rose petal appearance was prescribed on oral medications for 5 days. Later, she had presented with the complaints of acute onset left upper and lower limb weakness. Imaging done as a part of evaluation is shown below. The questions are uh, uh, to what is the etiology of the presentation and it is confirmed by the testing of what? We shall be moving to the next question. A 7-year-old boy with learning disability and behavioral problems being managed as ADHD from elsewhere had presented with new onset seizures with a GTCS semiology. He was evaluated with imaging of brain MR, which is shown in the picture right side. Describe the MRI findings and the most likely diagnosis, and what is the preferred treatment option in of this disease at early stage. We'll be moving on to the next question. A 6-year-old male child with learning disability and regression of his language skills on examination had a weight of 18 kilograms and vertical gaze palsy and frank ataxia. Due to a high suspicion of Niemann-Pick disease, genetic testing was sent, which was negative. In the background of a genetic testing being negative to confirm the diagnosis, which is the test that can be used now for this patient, and what is the neuroprotective agent of choice in this disease? We shall be moving to the next question. Uh, Name two neurological entities with this peripheral picture smear shown below, and what happens to the serum ferritin levels in neuroferritinopathy and aceruloplasminemia, respectively. We shall be now moving on to the next set of questions.
Question number 16. Parents of this 7-year-old male child notice increased throat clearing episodes from 5 years of age, which subsided on its own. Now there is emergence of these movements as shown in the video for the past 1 year, along with increased throat clearing for the past 1 year. The parents are unsure whether he can suppress these movements. It is not worrisome for the child. There's no history of OCD or ADHD. What is the diagnosis and how will you treat it? Question number 17. Identify the wrong pair among these. Trigonocephaly, fusion of metopic suture, scaphocephaly, premature sagittal suture fusion, brachycephaly, coronal suture fusion, plagiocephaly, fusion of metopic suture. Question number 18. A 12-year-old girl with a history of absences and GTCS has these light-induced stereotype events. The latter were occasionally accompanied by eye fluttering. Notably, her maternal uncle had childhood onset tonic-clonic seizure. What are these movements and how will you manage? Question number 19. An 8-month-old infant is admitted for intermittent episodes of generalized stiffening and posturing, occasionally associated with apnea and staring. These episodes most commonly present with 15 to 30 minutes after feedings. The infant is gaining weight and developing well. Most likely diagnosis in this case is, and how will you confirm the diagnosis? Eight-month-old child. Yes, ma'am. Around this thing. Question number 20. Which are the 3 most common genetic DOPA-responsive dystonias affecting children? And what will be the DAT scan in DOPA-responsive dystonias? 21. Match the monogenic conditions with current treatment in development. Prader-Willi syndrome, ganaxolone. Phelan-McDermid syndrome, minocycline. Angelman syndrome, mecasermin. Fragile X syndrome, oxytocin. Question number 22. A 17-year-old boy was brought to the emergency department after a new onset generalized convulsion that lasted for 6 minutes and was associated with urinary incontinence. Prior to this, he had been healthy but had just begun experiencing intermittent nausea and vomiting for 1 week without diarrhea or fever. It was coincident with starting a new fitness program and the intake of high protein supplements. On arrival in the emergency department, he was febrile with normal vital signs, lethargic but arousable to pain. Initial labs suggested an elevated ALT of 166 and ammonia of 787. The result of his comprehensive chemistry panel, including bicarbonate level, was normal and USG abdomen was normal. He was started on lactulose. However, after 24 hours, his ammonia level did not improve and he became less responsive. He had to be intubated and a CT brain showed diffuse cerebral edema. Prior to being started on dialysis, plasma amino acids and quantitative urine organic acids were obtained, which showed a low plasma citrulline level and high urine orotic acid level. Which enzyme defect is responsible for this condition? Number 23, a 4-year-old boy presented with significant global developmental delay with complete absence of speech, facial dysmorphism, and myoclonic seizures. His EEG showed the following pattern throughout the recording. The most likely diagnosis is question number 24. A 15-year-old boy presents for evaluation of weakness. Over the past year, he has developed weakness in the arms. On examination, he has 4 out of 5 strength in the bilateral biceps, triceps, and tibialis anterior. Additionally, he is unable to fully extend his elbows and he walks on his toes. Deltoid strength is intact. ECG reveals right bundle branch block and paroxysmal atrial flutter. What is the most likely diagnosis? Option A, Becker muscular dystrophy. B, Duchenne muscular dystrophy. C, Emery-Dreifuss muscular dystrophy. D, FSHD. And E, myotonic dystrophy. Number 25, a 6-year-old developmentally normal girl presented with recent regression in expressive speech and reading. She had 2 episodes of non-febrile seizures 1 year back and was started on an anti-epileptic drug. She was completely seizure-free afterwards. Her awake and sleep EEGs are given below. Which is the likely drug she was on? Awake recording and sleep record. Number 26, identify this prominent figure with respect to pediatric neurology. What are his contributions to neurology? Number 27, a 13-year-old boy presents for evaluation of muscle pain and stiffness over the past 1 year. He also notes that his eyes feel squeezed shut for a minute after he sneezes. His muscle stiffness is much weather and was especially severe after he recently went ice skating with his family. In fact, for a few hours after ice skating, he felt quite weak as well as stiff. On examination, he demonstrates a percussion myotonia at the thenar eminence and eye closure myotonia. Mutations in which of the following channels is most likely responsible for his presentation? A, calcium, B, chloride, C, magnesium, D, potassium, and E, sodium. Number 28, a 3-year-old boy born of consanguineous parentage presented with recurrent falls and toe walking from 2 years. Examination showed microcephaly, dysarthria, and bilateral foot dystonia. Neuroimaging revealed multiple areas of T1 weighted hyperintensities, including the basal ganglia and dorsal brainstem. NGS revealed novel homozygous single base pair insertion in exon 1 of SLC30A10 gene. Which electrolyte level should be tested and how should it be managed? This is the MRI finding, and F corresponds to a normal T1 weighted image. A 3-year-old boy of which electrolyte level should be tested and how should it be managed? Number 29, a 1-day-old neonate is noted to have significant hypotonia at birth. Is transferred to NICU for further management. Is noted to be diffusely hypotonic and to have a very weak suck and is in respiratory distress. Was born full term with via uncomplicated vaginal delivery. His mother, who is 27 years old, notes that when she shakes someone's hand, she has a hard time letting go. Trinucleotide repeat expansion in which of the following genes is most likely responsible for this condition? A, D4Z4, B, DMD, C, DMPK, and D, EMD, and E, ZNF9. Next question. Pediatric Moya MRI scale has good correlation with patient outcomes after surgery. Which of the following is not a component of the scoring system? A, degree of MCA stenosis, B, ischemic changes, C, hemorrhage, and D, encephalomalacia.
We will now be starting with the discussion of the answers. global developmental delay, and failure through time. The questions was to mention the MRI findings in a likely diagnosis. MRI brain image showed diffuse hypomyelination with basal ganglia calcifications, corpus callosum thinning, and marked diffuse cerebral and cerebellar atrophy. The diagnosis is cocaine syndrome, and this was from the article published from Chitra. The Cockayne syndrome usually presents with unexplained failure to thrive, short stature, microcephaly, and other characteristic features like sunken eyes, limb ataxia, abnormal auditory evoked response, or increased ventricular site with white matter changes. There are various polyneuropathies which are associated, but the most common is a sensory motor developmental polyneuropathy. Combination groups, Cockayne syndrome B, in which PD is the 80% with the gene of ERCC6, and the ERCC8 which was mentioned in this question is associated with CSA, which encodes a WD repeat protein. The second question, the sign shown here is the Gower sign, which is seen in multiple conditions like muscle dystrophy, BMD, sarcoglycanopathy, and Putin-related muscular dystrophy. It was classically described in DMD, and the FDA-approved exon skipping therapies for DMD are eteplirsen, which acts on 51 exon 51, golodicersen acts on exon 53, vitolarsen exon 53, and casimersen exon 45. The answer for the question is casimersen, as it was asked for exon 45. Sarcoglycan and LGD are the FTL. Question number 3. The 7-year-old child who had presented with insidious onset of right-sided focal motor seizures, which were drug-resistant, along with right-sided hemiparesis and cognitive decline. On a brain biopsy, there was a lymphocytic inflammation and microglial activation, with MR showing hemiatrophy on the left side. The likely diagnosis for this patient is Rasmussen's encephalitis. And the second question was, there were mentioned few options, and you had to find out the wrong match. The answer for the question is C, cladribine, because this is based on a paper which was published by Vardakar S and CG Bean. They have given a table in which the mechanism of action of different drugs have been mentioned. And cladribine actually acts by disruption of T and B cells and not by inhibition of microglia. Coming to the question number 4, this was a previously healthy 2-year-old child who had presented with acute, seemingly unprovoked onset of rapid, irregular, chaotic, and multidirectional eye movements with generalized shock-like and involuntary muscle jerks, affecting lip and tongue, leading to loss of independent ambulation and profound disturbance of sleep. The most likely diagnosis of this patient was opsoclonus myoclonus syndrome, and it is associated with neuroblastoma. The opsoclonus myoclonus syndrome is also known as dancing eyes and dancing feet syndrome. Approximately one half of children with this condition will be found to have an associated neuroblastoma, and it occurs at the median onset of 18 months and is rare in patients older than 10 years. The question B, which was the recommended initial treatment, is it should include a glucocorticoid plus IVIG rather than glucocorticoid alone. Here is a flowchart which shows the same, and the treatment has been divided initially whether the patient has a neuroblastoma. Glucocorticoid is written in this up to date is the question. The IVIG steroid and plus rituximab or cyclophosphamide can be used as an initial regimen in this disease. Question number 5, a 6-year-old child presents with a subacute onset of multifocal neurological deficits, including acute hemiparesis, blurred vision, and difficulty with balance, approximately 2 weeks after recovering from a common URTA. On examination, the child is lethargic and disoriented with demonstrable encephalopathy unexplained by fever or post-ictal state. The brain MRI image is shown. The most likely diagnosis in this is ADAM, acute disseminated encephalomyelitis. And the most commonly detected antibody in this age group is MOG antibody. They are detected in more than 50% of the children presenting with ADAM. And it is distinct. The MOG-associated disease is distinct from multiple sclerosis and NMOSD and is generally highly responsive to treatment with corticosteroids. Coming to question number 6, a 15 months child came. Question Question number 6, the 15-month child came with full growth, but suddenly one day woke up and no longer was able to speak as per the mother. Was diagnosed to have Rett syndrome. The most common gene defect of Rett syndrome and the specific treatment which was recommended were asked. The first answer is Rett syndrome is caused mostly by pathogenic variants in MECP2 gene, and trofinidin is the only specific therapy available for Rett syndrome. It is a synthetic analog of glycine, proline, and glutamate, a naturally occurring peptide. The exact mechanism is unknown by which this acts. Coming to question number 7, a 5-year child from Assam presented with high-grade fever and chills, and these are the peripheral smear slides shown. The diagnosis in this is cerebral malaria, and the organism is Plasmodium falciparum. The peripheral smear shows RBCs with ring-formed and banana-shaped gametocytes, which is consistent with the diagnosis of falciparum. As the patient is from the northeastern states, we have to add a ICT plus artemether lumefantrine combination in this treatment. Coming to question number 8, a 1-year-old boy who had preterm delivery with global developmental delay and congenital cataracts image has been shown. The likely diagnosis is congenital rubella syndrome, and the triad classically mentioned is sensory neural hearing loss, ocular abnormalities, and congenital heart defects. TORCH screening should be priorly done to detect this condition in mother. Coming to question number 9, a 2-year-old child was evaluated with cognitive regression. He, on evaluation, had low glucosylceramide activity in peripheral leukocytes. The histopathological finding shown is typical of Gaucher's disease, in which deficiency of B-glucosylceramide is seen. Accumulation of glucosylceramide causing leads to accumulation. This is the most common lysosomal storage disease with a classical triad of hepatomegaly, Gaucher cell in bone marrow, which is shown here, and increased serum phosphate. The description is that the cytoplasm is a crumpled paper or onion skin like. Coming to the second question, which phenotype of the disease has bony abnormalities? Here is a table showing the different disease types of Gaucher's disease, in which type 3B has classically severe skeletal findings, including vertebral compression, fractures, and osteonecrosis of long bones. Question 10, 7-year-old child with fever and sore throat was managed outside. After 3 weeks, had sudden onset involved movements of shoulder. The likely diagnosis is PANDAS, pediatric autoimmune neuropsychiatric disorders associated with streptococcal infection. And the preferred treatment option is azithromycin in a patient which is previously treated with penicillin or cephalosporin without a clear benefit. As azithromycin or clindamycin acts on the intracellular reservoir of the streptococcus, this is the treatment of choice in this condition. Here is the description of working diagnostic criteria for PANDAS. OCD or tic disorder. It should be a pediatric onset between 3 years and onset of puberty, abrupt onset of the symptoms and episodic course of the symptoms. There should be a temporal relation between group A streptococcus infection and onset of the symptom or exacerbation. The neurological abnormalities could vary from hypermotor activities and could also include coriform movements. Coming to question 11, a 5-year-old girl who was having a left optic pathway diagnosed as neurofibromatosis 1. Questions were the highest risk of development of optic nerve glioma is seen in the age range of first 6 years of life. Here a table shows the revised diagnostic criteria of NF1, in which caféolic macules and optic pathway glioma have been mentioned in this patient. The approved treatment option was the second question for particularly inoperable neurofibromatosis 1 related plexumum neurofibromas. Mitogen activated protein kinase inhibitors were approved for this, selumetinib and mirdametinib, one of which would give you correct answer. Question 12, a 5-year-old girl with vesicular rash with dewdrop on rose petal appearance was prescribed no oral medications and presented with left-sided hemiparesis. The etiology of the presentation is that she is a young stroke, and the diagnosis is right-sided MCA stroke due to varicella vasculopathy. It is confirmed by the presence of DNA in the CSF or demonstration of intrathecal anti-varicella zoster virus antibody. Question 13, the 7-year-old boy with learning disability had presented with new onset GTCS. The MRI was showing demonstrating the typical posterior pattern involving occipitoparietal and periventricular white matter and involving posterior and corpus callosum regions. Diagnosis is adrenoleukodystrophy, and the treatment of choice is allogenic hematopoietic stem cell transplant. This is providing an overview of the management of adrenoleukodystrophy. Question 14, a 6-year-old male child with learning disability and regression of language skills. Weight has been particularly mentioned to be 18 kgs, and a high suspicion of Niemann-Pick disease on evaluation showed a negative genetic test. The answer for this is Philippines staining in skill cultured fibroblast, even on a negative genetic test, could diagnose a Niemann-Pick disease type C. And the neuroprotective agent of choice is leucine. Here, in the type C, we have sorted it from up to date, and the positive Philippine testing in cultured fibroblast in case of negative genetic testing could be diagnostic of Niemann-Pick C. And leucine, also known as N-acetyl-L-leucine, was approved by the US FDA in September 2012 for neurological symptoms in children weighing more than 15 kgs. There was a peripheral smear slide shown, and so which is showing acanthocytes and two neurological indices in which this can be seen, and the serum ferritin levels in two particular conditions was asked. The conditions in which neuroacanthocytosis can be seen is chorea acanthocytosis, McLeod syndrome, Huntington disease like 2, PCAN. And neuroacanthocytosis with lipoprotein disorders include A beta lipoproteinemia, familial hypobeta lipoproteinemia, Anderson, and atypical Wolman disease. There are other systemic diseases where neurological findings and acanthocytosis could be seen together. The answer to question B is serum ferritin levels are high in aceruloplasminemia and low in neuroferritinopathy.
Question number 16 was of a patient, of a 7-year-old child with the stereotyped movements. And what was the diagnosis and how will you treat him? That was the question. The answer is A2 syndrome. And since he has mild tics and it is not bothersome, he'll be treated with medical management, clonidine or guanfacine. However, a CBIT, that is comprehensive behavioral intervention for tics, should be offered to all children. CBIT. The question number 17 was to identify the wrong pair. Among these, the wrong pair is plagiocephaly. It is not due to fusion of metopic suture. The common cause is prolonged pressure over the region that can cause posterior plagiocephaly. However, other conditions where plagiocephaly can be seen is because of unicoronal or unilambdoid synostosis, as shown. Then question number 18 was of a child with absences, 12-year-old child with absences and GTCS has these stereotype movements on exposure to sunlight. What are these movements and how to manage? These there is rare childhood onset generalized epilepsy characterized by photosensitivity and heliotropism as shown. And drug resistant movements are called hand waving episodes, which has a characteristic 3 to 4 Hz spike and wave discharges on EEG. However, ictal EEG findings may vary. Fenfluramine may be given for these stereotype movements with partial improvement. And the question number 19, an 8-month-old infant has these characteristic stereotyped events after feeding. The most likely diagnosis is Sandifer syndrome, characterized by paroxysmal spasms of head, neck, and back, and characteristically spares limbs. This occurs as a result of gastroesophageal acid reflux. Endoscopy with pH measurement can prove the diagnosis. It is mentioned that there is a successful treatment of the underlying GERD can cause a complete or near complete resolution of the neurological symptoms as well. Question number 20, which are the 3 most common genetic dopa-responsive dystonias affecting children, and what would be the DAT scan in dopa-responsive dystonia? The most common dopa-responsive dystonias are due to GCH1 deficiency, that is GTP cyclohydrolase 1 deficiency, tyrosine hydroxylase deficiency, and sepiapterin deficiency. All these conditions are autosomal recessive, except GTP-CH1, that is can have autosomal dominant with low penetrance as well. All of these conditions have mostly age at onset between neonatal to 5 to 6 years, except for GTP-CH1 deficiency, autosomal dominant, where there is a variable period between mentioned here, that is 0.2 to 48 years, and all of them present with generalized dystonia, and all of them have diurnal variation. Excellent response to levodopa is seen in GTP-CH1. However, good response is seen in with partial recovery, partial improvement in tyrosine hydroxylase and sepiapterin reductase. Levodopa-induced dyskinesia is more prominent in tyrosine hydroxylase deficiency. DAT scan will be normal in dopa-responsive dystonia as opposed to Parkinson disease. Question number 21 was match the monogenic conditions with the correct treatment and development. The answers were for Prader-Willi syndrome, oxytocin, as there is deficit in oxytocin neurons, and Phelan-McDermid syndrome with mecasermin, which causes activation of AKT pathway. Angelman syndrome with minocycline that increases long-term potentiation, and Fragile X syndrome with ganaxolone, which is a GABA-A agonist and increases deficient GABA-A signaling. The sources from Continuum, and these are the other medications in Fragile X syndrome. Question number 22 is a 17-year-old boy who was found to have a low plasma citrulline level and high orotic acid level after global stable edema and OSCE. The answer lies in the mainly the clues were in history there was high protein intake just prior to decompensation, which suggests of an amino acid metabolism defect, and very high ammonia without metabolic acidosis, which suggests a urea cycle defect. So there is low plasma citrulline level and high urine orotic acid level. So the pathway that is affected and the enzyme affected is ornithyl transcarbamylase defect. Question number 23, a 4-year-old boy with significant global developmental delay and complete absence of speech, facial dysmorphism has this characteristic EEG pattern, which is showing frontally dominant notched delta pattern, which is characteristic of Angelman syndrome. The facies of the child also gives the clue to the diagnosis. A 15-year-old boy presents for evaluation weakness, and he weakness over bilateral biceps, triceps, and tibialis anterior, and had difficulty extending his elbows. An ECG showed right bundle branch block and paroxysmal atrial flutter. There was a deltoid sparing as well. The diagnosis would be, the overall picture is most consistent with Emery-Dreifuss muscular dystrophy. He has weakness, contractures, and early cardiac involvement, and occurs in first or second decade of life. Duchenne and Becker's are less like Becker's muscular dystrophy is less likely in this patient because of early cardiac involvement and deltoid sparing. FSHD is less likely. There are no facial weakness. Described myotonia in this case to suggest a myotonic dystrophy as the diagnosis. Question number 25, a 6-year-old developmentally normal child presented with recent regression. She had a past history of non-febrile seizures 1 year back, for which she was added on an ASM, and she became completely seizure-free afterwards. Her awake and sleep recording showed, awake record is this, there are focal epileptiform discharges from central and right parietal, right temporal, centrotemporal spikes are seen in the awake record. And in sleep, this is the pattern that is seen, that is amounting to CSWS. So the diagnosis most likely is LKS. It shows bilateral centrotemporal spikes and wave discharges right more than left in the awake with marked activation and slow wave sleep. The most likely drug she was on must be carbamazepine, which has which is a known agent to induce CSWS in children with benign focal epilepsy. Other drugs that are implicated could be phenytoin and phenobarbital. The prominent figure shown in this picture and his contributions to neurology. This is Dr. Frederick Batten, and his major contributions are, he's the father of pediatric neurology. His major contributions are in describing Batten's disease, which is earlier known as family cerebral degeneration with macular change, subacute combined degeneration of the cord, and myotonic dystrophy. Question number 27, this 13-year-old boy with particular muscle pain and generalized muscle pain and stiffness, as well as this feeling of eyes being squeezed shut after sneezing, and with the worsening after a cold exposure, and demonstration of percussion myotonia and eye closure myotonia on examination. The mutation must be in this condition is paramyotonia congenita, and the mutation must be in sodium channel. The clues were a worsening of myotonia with cold and associated muscle weakness, and eye closure myotonia induced by sneezing, especially repetitive sneezing. The causative mutation is in SAN4A. Chloride channelopathies can cause myotonia congenita, and calcium, other sodium and potassium channelopathies can cause periodic paralysis. Question number 28 was of a 3-year-old boy who started having recurrent falls and toe walking, and examination had microcephaly, dysarthria, and bilateral foot dystonia. He was found to have a SLC38N gene mutation, and the imaging showed bilateral basal ganglia T1 hyperintensity and posterior tectal T1 hyperintensity, as shown in this figure. So manganese level should be tested in this patient. This is manganism, and EDTA chelation would lead to improvement. Question number 29. A 1-day-old infant was found to have significant hypotonia and required intubation. The mother now gives history of difficulty ungripping hand. So the likely diagnosis must be myotonic dystrophy, and DMPK gene, DMPK repeat nucleotide expansion is the causative expansion, and maternal anticipation is evident in this case. D4Z4 mutations cause FSHD, dystrophin mutation cause Duchenne and Becker dystrophy, DMD mutation cause Emery-Dreifuss muscular dystrophy, and ZNF9 cause EMD, EMD mutation causes Emery-Dreifuss muscular dystrophy, and ZNF9 mutation causes myotonic dystrophy type 2. Last question, pediatric Moya MRI scale has good correlation with patient outcomes. Which of the following was not a component of the scoring system? The answer is degree of MCS stenosis. The ischemia, encephalomalacia, and hemorrhage are the components of this individual components of this scaling, which is used to predict outcome after Moya surgery in these patients. In the panel 1, A, B, C, and D demonstrates a high score with bilateral MCS stenosis and encephalomalacia over the left side, and infarct over bilateral subcortical infarcts and a punctate hemorrhage. And the lower panel demonstrates a good score of 0 without any of these findings. We're winding up the session. Thank you for patient listening.